I'll wait another minute or so before um, before we get started, so we let extra students join us if they want to.
Professor Zeller, I sent you a chat. Did you see it?
Yes, I did, Sway.
Okay.
Yes, yes. Okay. Yeah, no, the last couple of weeks of class, we've had a lot of sickness. It's that time of year, I guess. I know I had to take extra allergy pills today. Okay, welcome, 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 everyone. If you are having trouble um, trying to prepare for the HESI, I haven't heard from many of you at all. So if you need some even better guidance, but I'm going to give you some in a minute here. Please reach out to me. I haven't hardly spoken to anyone in a few days, so I am available tomorrow and Friday if you need anything. Um, oh my goodness. And I'm so sorry to hear what's going on with you, your family. Apologize. You can leave your camera off if you want to. I understand. Okay. So this is HESI Review Week. We don't have extra sessions outside of our class time like we normally do for exams. I think that was a misunderstanding. But you are invited to attend um, other classes this week if you have time and energy and you're not sick and you just want to listen to another instructor. I am putting the recordings. The very last announcement I posted has the recordings. And Professor McBride, this is from Professor McBride's Monday class. And then my recording was for my 2 o'clock class today, which was really good. So I posted in there and I took off Mondays. Mondays wasn't as good. So I didn't want to I didn't want you to spend so much time watching recordings. And if I didn't think it was as good, I'm not going to post it. So the one I just did it to was a really good review, and I expect this one to be good too. From the feedback that I got from Monday, made me change what I wanted to talk about during class, and that's why I changed everything up. Okay. So, in looking at your announcements on your class, if you go back, there's HESI information, and this is the one that has all the information in it that I could come up with about the HESI itself. It gave you some readiness recommendations. So I was hoping that that would help you at least get started on getting ready for the HESI. And so I do recommend extra NCLEX questions, and I recommend that you go back into your simulation charts. Look at the feedback that I've given you. The feedback that I have given you in each of these sim charts are key points that you need to understand. Okay. If you had an error in a question, I might have addressed that specifically. But I felt like the sim charts were excellent, going back over through them, reading your questions, your quiz questions, reading the rationales were really important because they were excellent. And we're going to do some of that today. There is a book called HESI Comprehensive Review for the NCLEX examination, and it's a book, and you should have it in your online library or your virtual library, I should say, or you should have the book, or it should be on campus. Anyway, this is a great book, and I think you should go in there and look at it and read what I tell you to read. There is a drag and drop examples, all the different kinds of NGN style questions, and you'll have several on your HESI exam. These are different than what you're used to. So that's why I gave you some samples or some page numbers to look at. And these pages that I'm giving you are actually OB cases. And this book is good for your med surg class as well. Go through, because there's a lot more med surg questions than there are OB. So, really use this book. And you can go back and use this book for taking your actual NCLEX, your real NCLEX. Okay. If you scroll down, there's some previous videos that you can watch, recordings. And then the HESI Key Topics PowerPoint, we're going to cover some of that today. Calculations. It's a very weak area for Fortis students. Across all campuses, for some reason, Fortis students don't do as well as the national average. So we need to improve that reputation. So if you still need help with math, please reach out to me before you take your HESI. Okay. And then there's other resources here. And it also tells you how to register for the HESI. Has anybody had any trouble at all registering for the HESI?
It's not even on the site yet for you to register for it. For me, rather.
Oh. Okay, so when you go in there and you don't see it, Latoya, click on your name, which is on this left sidebar, and clear out your cohort. It might show up then.
Okay, I'll try that and see.
Yeah, and that's in here. That's in this announcement. Remediation for your HESI is mandatory. Everybody, no matter what your score is, you will in the Evolve account. When you go to Evolve, you register through your Evolve account to take your exams, and then when you're completed the HESI exam, you'll receive a remediation packet in your Revolve account. Okay, so everybody is required to do an hour's worth of remediation. So this is how you should do that. Okay, get into your remediation packet and complete all the case studies first, because you have to complete them all and do the best you can. And 80% is what's required. Okay. And let's say your score was 789 on your HESI. So you need 4 hours of remediation. Okay. So spend all the time you need on your case studies. If you have an hour left over, let's say you spend 3 hours on them and you still have an hour to spend, that's when you go to the essential packets, okay, and spend your remaining hour there, okay? If you only have to do an hour, you still need to do the case studies, okay? If you don't receive anything, no packet, let me know, and you probably won't have to do anything. That means you scored super high, okay? Keep in mind, if you don't do your remediation by, I think it's Tuesday, no, it's not March 16th. What would it be? What's today? I need to fix that. Anyway, in week 12, you need to complete all your remediation by Monday night. Okay, Monday night. All right. So look through that announcement. Let me check something real quick. This is week 10. So it would be the 24th. The 24th, not the 16th. Okay, I'll fix those. All right. So that's that announcement. I also want to cover the recordings. Now, oh, I did that already. Wait a minute. Let's see. All right. All right. So everybody knows that they take their HESI on campus, correct? You won't be on Zoom next week. We don't have class next week because you're doing your HESI instead. So don't contact me at 2:30 next Wednesday and say, Dr. Zeller, aren't we having class? No, we're not next week. But we will have a brief class in week 12 at Wednesday, 5:30, okay? A brief class, week 12. All right. So next week you do your HESI and you have class time off. Any questions about that? Okay. Let's see. So what we're going to do today is we're going to go over the sim chart scenarios. And I'm not going to actually access the sim charts. That's what I tried to do on Monday. And it didn't work out too well. So what I did is I put them, what I thought was important in this PowerPoint instead. And then we'll go into the HESI key topics PowerPoint, which is what you all should have downloaded by now. And we'll pick out what we want to talk about. And then if we have extra time, we'll start the beginning with that. So if at any time you have a question, please interrupt me. My class at 2 today, they interrupted me a lot, and it was good. So I want you to do the same. All right? So any questions right now from anybody? Okay, let's get started. So we're going to cover the simulations, intimate partner violence, infection, postpartum bleeding, preeclampsia, previa, neonatal resuscitation, and then this week you're working on hyperemesis gravidarum, and I'll give you some notes about that. Now, if you've already done it and you did poorly, send me a message in chat, and I will reconsider your grade, okay? All right. Since it might not seem fair to those who've already done this and they didn't do well, and then some of you would have the advantage of maybe doing better, okay? So just let me know. All right. So the truth about intimate partner violence. So this is intimate partner as well as domestic or human trafficking. Okay, it's all kind of the same. So it's found to occur in all family types, in all races, in all social economic populations, all ages. It doesn't particularly pertain to one population of U.S. citizens. Pregnancy increases the incidence. It increases the risk within a relationship. So if you have partners and there's already stress in the relationship, pregnancy is going to make it more difficult and the risk for a very first episode can occur. If there's already IPV or trafficking occurring in her life, then pregnancy is going to make it worse. That's research-based and the truth. So we have some responsibilities as nurses to screen and be alert. And anytime we have an opportunity to provide support and information, we should do it. I know that this is not a specialty area for me, and neither is mental health. I do know some things, but that's not my specialty area. And certainly it isn't for you. So it's hard to sometimes approach these patients. You can learn about IPV. The more you know about it, the more you'll be able to know how to approach women that are showing evidence of maybe possible abuse. But as nurses, we should screen every time a patient presents for a visit. Women should be, and men, should be screened if they go to the hospital. Psychological abuse is not always evident. It's not something you'll always see. You have to have a very trusting relationship with your patient, and you have to learn to use an open-ended questions and stimulate their conversation. Okay. And another thing that this scenario brought out was that screening should occur after delivery, not just during the pregnancy. It should continue to occur as they're going to pediatric visits. Anytime they go to any facility for care, it needs to be brought up, as well as substance abuse and all those things need to be addressed. We tend to ignore that. I find that providers are so focused on those lab results, they forget about everything else about our health and well-being. We need to learn what holistic nursing is. And part of that is social, emotional, psychological relationships, things like that, and communication. So this scenario also covered abrupted placenta, didn't it? And I know it was hard for you because we hadn't even discussed a placenta and the bleeding that occurs when it pulls away from the uterine wall. We haven't even discussed it, and you had to do a scenario. But let's go back. A patient should never be asked about abuse or what she experienced in front of the abusive partner. That puts her at a greater risk for more abuse, as well as giving her a website to go to. If she's going to go to that website, she needs to do it outside of her own home. And go to the library, go somewhere else where there's computers, and get on to look at that information. Handing her a document is also risky, because what if her partner saw it? That could cause a problem. So it's tough. It's tough to give them information. As nurses, we need to document exactly what the patient is saying to us. We don't want to summarize what they're saying because we could be wrong. Just document what they're saying and confirm them with a statement and put it on the record. And then when we examine her, we always have to ask her permission. Okay, if she's been abused, we have to ask her permission. And then nobody else needs to be in the room. We don't want the abusing partner to be in the room when we examine her. It gives her an opportunity to talk and to open up. And it makes her feel safer if the perpetrator is not in the room when you're talking and examining. Okay. So placental abruption after abdominal trauma is usually seen. We can see evidence of it soon as the injury or shortly after the injury. Now, this could be abuse, right? Or it could be from a fall or a motor vehicle accident. And I think in this scenario, it was abuse. She said when she came in that she fell down the stairs, I believe. But when we excused the partner, then she told us the truth, about what happened. So if she's not feeling badly, then we initially assess anything, ask her if she's bleeding, and she says no, she's having some discomfort, then the first thing we need to do is hook her up to a fetal monitor to see how the baby is doing. Okay. So we need to monitor her at least 4 hours after any kind of trauma. We're looking for the onset of uterine contractions, or increasing uterine contractions. And then if we do a cervical examination, if there's increased contraction but no changes in the cervix, those contractions might be caused by bleeding that's occurring, and it's covert bleeding. In other words, we can't see it. There's no evidence of it. It's behind the placenta. So we need to make sure the baby's doing fine. So the sign of an abdominal pain, the sign of a placental abruption is severe, abrupt abdominal pain. Okay. Bleeding like I said, bleeding might be visible or it might be concealed, but we need to assess how the baby is tolerating the bleeding. Okay. Usually, if there's bleeding going on, the uterus is very firm, very rigid, and it might be tender when you palpate it. You might see tachycardia if she's bleeding a lot and you don't see it. So if she's complaining of pain, she's having contractions, and when you palpate her uterus, it's very tender and it's rigid, and yet you don't see any bleeding, you would see fetal, maybe minimal variability, or tachycardia in mom. So as a reminder, the normal fetal heart rate pattern, the baseline fetal heart rate should be between 110 and 160. Okay. The presence, and there should be moderate variability within that heart rate. If you don't see moderate and it's minimal, it could mean several things. It could mean that the baby's asleep, or you gave her something for pain, a narcotic in particular. If you gave her a narcotic because she's in so much pain, that could change the variability on the heart rate of the fetus. Other things it could mean fetal hypoxemia. The bleeding has restricted oxygenated blood from getting to the placenta and then to the fetus. Metabolic acidosis. In other words, the fetus doesn't have any energy reserves and doesn't have the oxygen. And so you might see changes with minimal variability. Or it could be congenital defect. Maybe a neurologic injury has occurred. So those are some things that you might see with minimal variability. Minimal variability needs to be followed up. Okay, so that was the intimate partner violence and abrupted placenta. Any questions about that? So there was a sim chart about infection. It also included therapeutic communication. Okay, so group beta strep microorganism. It's commonly found in the urine, in the gut, in the vagina. People just carry it. Okay, and it's not anything we treat. We don't consider it an infection. Okay, so when we're doing our first prenatal visit, we do a urine culture or a vaginal culture, and the results come back that there's group beta strep there. We know that when she goes into labor, we need to give her something to treat it. Okay, during the pregnancy, as long as her membranes are closed, it's not a problem. Okay, we do cultures between weeks 36, week 38, to just routinely on every woman to double check for colonization of group beta strep, or maybe herpes check, or any kind of sexually transmitted infection, because those things can cause early labor. Okay. So if our mom is GBS positive, and you'll notice probably at the top of a patient's chart, the patient's name, allergies, and all of that, and GP status, GBS status, they want to know right away if she carries GBS. Because if she goes into labor, we need to start penicillin. Okay, penicillin infusion to destroy the GBS before baby travels through that birth canal. If baby comes in contact with GBS, it can cause pneumonia in the baby, meningitis, any of those things. As far as therapeutic communication, in the fundamentals nursing book, and this is the 9th edition, I believe, yeah, page 327, it has a list of things about therapeutic communication, and you could go back and just read that and jot down some notes as a reminder. It's amazing how something as simple as that can help you with one exam question. So this case also talked about penicillin allergies. So there are many people who might have received penicillin when they were a child for an ear infection or something, and they had a rash or something. And so they think they're allergic to penicillin, and they'll tell the provider, oh, no, I don't want penicillin. I had that and I had a rash. Well, a rash is not a serious allergy. And most children outgrow their allergy to penicillin. And so only about 10% of the adult population has a true hypersensitivity to penicillin. And what we usually see with adults that have a hypersensitive reaction, an allergic reaction to penicillin, is usually shortness of breath because their throat swells and their lips swell. Angioedema and shortness of breath, serious signs like they can't breathe. That's an anaphylactic reaction. And if they ever tell you that they have that with the drug, that is definitely a serious allergy, and it needs to be noted on the chart. Okay. Placenta previa is what we want to talk about next. Or let's see. No, let's talk about preeclampsia. Oh, well, no, let's go ahead and talk about previa. So previa, remember when this patient presents with bleeding, she's having some vaginal bleeding, and she has not been diagnosed with a previa in the past in her pregnancy. It doesn't tell you how far along she was, I don't think. If usually if there's a complete previa, they're going to bleed earlier. They're going to bleed by their second trimester. Okay. The very first thing that we notice in the scenario is that the patient tells us that her baby's moving a lot. Okay. So that's a good question to ask a patient that presents with vaginal bleeding and you have no idea what's going on. ask them, how's your baby moving? If they tell you baby's moving a lot and moved today, well, then the bleeding that she's experienced isn't affecting the fetus. If the baby is moving, that's a good sign that the fetus is tolerating it well. Okay. But once you go ahead and hook up the monitor to the baby or to the belly to look at the fetal heart rate pattern, and once you're reassured that way as well, then you need to investigate her bleeding. Okay. Because she came in and her vital signs are stable and she's having bleeding, check on the fetus first. Okay. If she wasn't stable, then we would treat her, investigate, put an IV in before we put a fetal monitor on. Okay. Because we have to stabilize her before we can do anything with the fetus. Okay. So the next thing you would do then is to get a volume of how much blood loss she has had. Okay. And go from there. All right. Let's postpartum hemorrhage. How many of you remember the medications we use for a postpartum hemorrhage?
Pitocin.
Pitocin. Or oxytocin.
Is it oxytocin?
Oxytocin. Yep. Yeah, that's the first line. That's the first drug choice. Every facility usually has a hemorrhage protocol. They might even have a hemorrhage cart that has medications in it, has an IV bag in it, things like that. Okay.
You want us to name some other ones?
What?
Oh, you want us to name some other ones or just Tosa?
No, that's fine. That's
Oh,
fine.
okay.
I'm pulling up postpartum hemorrhage here. All right. So remember postpartum assessment. In this scenario, SIM chart, I didn't think it was as good as the rest of them, but because it didn't even mention medications. So remember in your postpartum assessment, if you receive a patient as postpartum, we are usually doing vital signs and assessments of the uterus and everything else every 15 minutes for a while. And then as long as we know she's stable, then we can increase to 30 minutes to recheck. So don't forget to recheck your patient. She could be stable at 30 minutes and maybe the next hour. Everything looks good. She's not bleeding too much. Her uterus is contracting, but 3 or 4 hours past delivery, she's not getting up to go to the bathroom, and then she starts bleeding. Okay, so we have to routinely, every 30 minutes or so, check her uterus. So the priority in postpartum assessment is the uterus, not the breast. We check it later once we know our patient is physiologically stable. So we look at, let's see. We're assessing the uterus. That's the first thing we do. Is it contracting? Where is it located? So if you go in the room and you notice, and we always do inspection first, right? Inspection is always first. You're looking at her lower abdomen and you notice that it looks like the uterus might be deviated. It's not in the middle like it should be. And it might be higher in her abdomen than what you expect. It should be right at the umbilicus. And maybe it's above the umbilicus to the right. That should tell you right away that her bladder is probably full. So you're looking and then you're palpating the uterus to see if it is contracting. Does it feel firm? If it doesn't, what do you do?
You massage it?
Okay. Massage that uterus because you want to stimulate it to contract. Okay. What if it starts contracting? Then what would you do? Other than be happy, what would you do if it's contracting? It's kind of hard to think about this if you're not standing in front of the patient, right? So when you saw the uterus, it was deviated. You did massage and it did start to contract. Now what do you want to do?
If it's deviated, don't you want her to go to the bathroom?
Okay, yeah. So let's get her bladder empty. So it will continue to contract, right? Yes, Rosa, that's right. So get her bladder empty. Empty her bladder. Now, if she had an epidural, it might be a little more challenging for her to empty her bladder. She might not feel that sensation. So that's why we have to remind them that it's important for them to go to the bathroom every hour or two to keep the bladder empty so the uterus can contract. All right. So it's really important. Let's say her bladder is empty and her uterus is still not contracting very well. What are some things that we can do to help it contract?
And breastfeeding help
Let it-
contract?
Okay, breastfeeding certainly can. That stimulates oxytocin release.
You could give oxytocin.
Yeah, you can give a higher dose of oxytocin. You can either restart it if it's not running, restart it, get it going so we can stimulate that uterus. So, and then we have other medications we can give. Methergin, usually the second line. Unless she has high blood pressure, we're not going to give it. Hemabate, we can give that as well. Both of those are intramuscular injections. So the Hemabate, you wouldn't give it to someone with asthma, right? And then prostaglandins. Prostaglandins at a high dose can cause uterine contractions. Okay. All right. So make sure, let's say you have a patient that's bleeding, the uterus is in the right location, it's contracting, the bladder is empty, but she's still bleeding too much. What's going on in that situation? Or what could be going on? Marisol, do you know?
I'm not sure.
Okay.
Can you repeat
Anybody?
the question?
Yeah, what if her uterus is contracting not nicely? It's in the right location, but she's still bleeding a lot.
Wouldn't you have to check how much blood is her output is?
Okay, definitely. And you figured out this looks like too much bleeding.
And
Could
right.
it be a retained placenta?
Yeah, it certainly could be. But usually if it's retained placenta or extra clots, then the uterus isn't going to be contracting as well. Okay. What else could it be? Anybody have an idea? Whitney, do you have an idea? Why is she bleeding? If it's not the uterus, what could it be?
Endometrius. Like she's pregnant. I don't know. I mean, we said that she may have had a piece left in her. It wasn't that. Um, mm, I don't know.
The episiotomy?
Yeah, the laceration. She might have had a laceration that the stitch broke loose, or we didn't observe it. It could have been a cervical laceration. We didn't notice at first. And that what could be bleeding. So no amount of medications or ice or massage is going to help. You know, we need to notify the provider. A vulva, hematoma. All of those can cause, those are the secondary causes of hemorrhaging are hematomas and lacerations. So if your uterus that you're observing is contracting firm, midline, the bladder's empty, and you notice bleeding, other than knowing how much, we need to examine her and see what's going on and call the provider. Okay. There was one question about applying ice. Now, applying ice to a vulva hematoma is comforting, okay, because it's uncomfortable, but it's not going to stop bleeding of the hematoma, and it's not going to stop bleeding from a laceration. It's not going to stop uterine bleeding, okay? So call the provider. Unless I give you permission, you need to be on camera, okay? A lot of you are coming and going. It's kind of the way it is in week 10, okay? All right, let's see. So what would you see if your patient what is the first sign of too much bleeding, postpartum hemorrhage? What's the first sign?
Tachycardia.
Tachycardia.
Yeah, tachycardia. Okay, so there are baroreceptors in the carotid artery. These are specialized cells that sense that the blood volume or the blood pressure is not as high as what it normally is. It's very sensitive. It's before we would notice a change in the actual blood pressure reading. So when that happens, that sends information to the regulatory system of the brain, which is the medulla. And the medulla stimulates the heart to beat faster, okay, to try to make up for the volume loss. How do you know your patient's going into shock? It's on the slide on the bottom. So if you see your blood pressure drop, right?
Tachycardia.
And tachycardia is still there, blood pressure drops, cool, clammy, pale skin, she's going into shock. Her skin is cool, clammy, and pale because the blood is being diverted to the major organs, the brain, the heart, mostly. Okay? So that is shock. We don't ever want to get that far. So it's important that you assess and watch your patient. Let's see. Let's go over this one. This was one of your scenarios. I changed it a little bit. Okay, Sarah M. is 30 years old. She has gestational diabetes, and she comes into the ER at 34 weeks with shortness of breath. And she says her head hurts. Now, James, you can't say anything about this. Why? What would you do? You're the ER nurse. You've seen quite a bit of OB. Most people in the ER department, if an OB patient comes in, they want to immediately move them on up to the OB unit. Okay. So let's say you're working in OB and here comes this patient and they give you a report. They have her on oxygen and her head hurts, and you take over admitting her. What would be the first thing you would do? Would you say,
Check
Rosa?
blood pressure.
Check her blood pressure.
Yeah, check her blood pressure. Yay. Good. Yeah, we want to rule out something, right? If her blood pressure is 134/80, we're not concerned about preeclampsia, right? Yeah, so we just need to ask her we need to talk to her about her shortness of breath, because that can be common in pregnancy with some palpitations. It can be common. But the headache we need to address and just assess to make sure she's doing okay. But if her blood pressure is elevating, what would you do next? You're going to say, oh no, preeclampsia, right? That's what you're thinking about.
Start her on
Why is she?
magnesium.
Okay, magnesium would be certainly one thing we'd want to do. So what is it about shortness of breath? What does that have to do with preeclampsia? Angela?
I was gonna say like applying the oxygen for that shortness of breath. I forgot. I'm thinking about it. Because doesn't they have to got something to do with perfusion? I gotta think. My head everywhere.
Okay. It does have something to do with perfusion.
Yeah. It's right there. I'm telling you, Professor Zeller, but Lord, it's there.
Okay. James, do you remember?
The perfusion of edema, pulmonary edema.
Yeah, pulmonary edema with preeclampsia. So if the blood vessels that are surrounding the pulmonary alveoli and lung tissue aren't perfused well because of vasoconstriction, then the pulmonary tissues are going to become edematous. Okay, and so she's going to have trouble breathing, and there's not as much exchange taking place. Okay, so shortness of breath, pulmonary edema, is a serious sign of preeclampsia. Okay, and of course hypertension. So magnesium sulfate is definitely the first thing we want to do. But what if her blood pressure is 164/100? What would be the first thing you'd want to do? Here she is. You take her blood pressure, and it's 164/100. She's having shortness of breath. She does have some oxygen on, and she has a headache. In this list, what would you do first? And just because it's in purple doesn't mean it's right.
Would it be the stress test?
Seizure precaution?
Labetalol.
Seizure precautions, yeah. But what do you want to do first for her?
Administer labetalol to bring down the BP first. That's the most chronic thing.
Yeah, it's the most acute situation because we don't want her to have a stroke. Let's get her some blood pressure medication. Okay. So we have labetalol we can use, very common. And this is usually prescribed as PRN in this situation where keeping the patient's blood pressure below 140 or something, give labetalol 20 milligrams or something every 30 minutes to keep that blood pressure down. So let's say we've given her that. What else can we do? What else should we do after that?
Check the baby, monitor the baby heart rate.
Okay, let's look at the baby. You want to look at the baby, okay? We don't need to do a non-stress test until we know what the baby is doing. Okay? What else should we do?
Shouldn't we get a detailed history of her symptoms? Or
We
no?
should. But do we want to do that next? So she's in the bed, shortness of breath, oxygen's on, and you're giving medications to keep her blood pressure down. What else do we need to do? What's a priority?
Give her magnesium sulfate.
Magnesium
Okay.
sulfate.
Yeah, physiological stability. And we need to protect the fetus, right? Because the fetus isn't getting adequate blood flow either. So we're going to give it not only for seizure prophylaxis, but for neuroprotection for the fetus. Okay. And then we can obtain a detailed history. Everybody understand that? So the first thing we'd want to do is address her blood pressure. And then look at the heart rate. And then start some magnesium. Okay? So let's say you've been giving her medications. She got magnesium going. She's got labetalol, several doses of it, and her blood pressure is 150/90 still. Her oxygen is on. Baby's doing fine. And you notice that her urine output has only been 20 over the last hour, and her platelets are at 80,000. Now, what would you do next?
Notify the healthcare provider.
And what's your rationale for that?
Because of the pressure remains, her blood pressure still remains at 150/90 after giving the medication.
You're right, Marisol. Her blood pressure is still high, and her labs are dropping.
Because of the worsening of the symptoms?
What?
Because of the worsening of the symptoms, I guess?
Because of worsening of lab values and her blood pressure. Exactly. So you don't want to increase her IV fluid rate because her blood pressure is up and she already has pulmonary edema. We don't want to increase fluids. That's not necessary. We've already given some labetalol. It should be another dose. Apparently it's not working too well, or something else is going on. HELLP syndrome. So worsening thrombocytopenia, which are the platelets, and oliguria indicate potential progression to HELLP syndrome or severe preeclampsia, which demands notification to the provider. And then we need to prepare for a C-section. Okay? So we need to treat HELLP syndrome like we treat preeclampsia, but we also recognize that the only way truly to resolve the problem is to deliver the baby. So the gold standard for any preeclampsia is magnesium sulfate, because it improves circulation to all those areas that are being injured. The brain, central nervous system, the lungs. It'll help with her breathing problems. It'll increase her kidney function, improving her urine output, and it'll help decrease liver injury. Okay, so knowing all of those things, we need to monitor all those things, right? We need to monitor her for headaches. What else? So what are we monitoring during this whole scenario? What things are we looking at? We've talked about blood pressure. We've talked about labs. What else are we monitoring?
Level of consciousness.
Level of consciousness. What else do we need to be assessing and documenting? Danielle, do you know? What else do you want to monitor for your patient?
Would it be the her signs of health, the fetal heart rate?
Okay.
Are we supposed to do the deep tendon reflex?
The deep tendon reflexes, yes, Ashley, exactly. Don't forget to assess her deep tendon reflexes, her muscle strength, everything that has to do with the central nervous system. Check her urine output. So it's been 3 hours now since you started the magnesium. And you're having trouble waking Sarah up. So what are you seeing that you suspect that she is now at a level of toxicity of magnesium in her blood?
Respiratory rate of 8 breaths per minute.
Yep.
The deep tendon reflexes, 1+.
Yeah, so normal is 2,
The
right?
urine output.
Mm-hmm.
Urine output of
Urine
50
output.
an hour.
Is that bad?
that
Urine
ain't
output of 50 an hour?
Yeah, that ain't enough.
Well, we can accept 30 an hour, right?
Okay.
Yeah.
Slurred speech, but you said she was asleep.
She has trouble waking her up.
Oh, okay. Well, yeah. I would think anything with slurred speech, but
It's not a good sign, right?
nah, because if you was talking normal beforehand, why are you slurring?
Yep. It's just like if her brain wasn't getting adequate perfusion, if she had a blood clot or she had a bleed in her brain, she's going to show signs of a stroke. And slurred speech is one of those. Okay. Very good. So the last set of labs you get, platelets started out. So anytime you have a patient in the hospital, you always look at trends, right? This was her creatinine here, and now look at her creatinine. So we're always looking at trends. So she started out with low platelets, but not too bad, 100,000. And then they dropped to 80. And the last set was 65,000. Her liver enzymes almost doubled, and they were already high when she was admitted. They should not be much more than 40. Okay, and then creatinine. So creatinine is a measurement of kidney function, and everybody should not be any higher than a 1. So she started at 1.2 and she reached 1.8. So she's going into failure here. Right. So based on this, we have to prepare for what?
Would you give her a bolus? Or no?
No, no.
No, not for the
Emergency delivery? Or?
Cesarean, right?
Yeah, deliver the baby. We have to prepare for a C-section. Okay. We don't want to put her in labor. That'll make it worse. We have to do a C-section to deliver that baby. Okay, so in your discussion 3, we had Mrs. Rivers, and a lot of you did well on this. A lot of you didn't. I mean, it's okay. You learn from it, I hope. But she's 40 years old, and she's a diabetic, type 2 diabetic. She's at risk for preeclampsia just because of those 2 things. And she said she's let's see, she felt fine and she noticed some swelling in her hands, her feet, and her face, which are not uncommon in pregnancy. But she said she has a headache, and acetaminophen has not helped her. So the headache alone should prompt you to want to get her blood pressure. Some of you didn't put that in your discussion. You wanted to address the insulin problem or the lack thereof. Okay, so high risk for preeclampsia, a headache. The first thing you always want to do is get their blood pressure and deal with that before worrying about the insulin. Okay. When they mentioned that the patient asked about insulin needs during pregnancy, that kind of threw some of you off. And you gave us really good backing of why we needed to educate her and send her to a dietitian about her insulin. And that's good. Yes, we do need to do that. But the priority is assessing whether she has preeclampsia going on. And so we need to get that blood pressure. If her blood pressure was normal, then we definitely address the insulin problem. But we need to deal with the preeclampsia first. Okay. Let's take a break. It's been an hour, so we'll take a break for 15 minutes. So 5:40 or 6:45 or 3:45, wherever you are in this United States of America. 15 minutes. Okay. Let's get started again. So let's talk about neonatal resuscitation, which was last week's sim chart. I don't know if you have to know about the actual steps of resuscitation, but I do want to kind of highlight what the focus is for resuscitation and how it relates to APGAR. So remember, when a baby is born, we have a full minute before we actually do an APGAR. Okay, so if a baby is born not breathing or crying, limp, no muscle movement or reaction to any kind of stimulant, then we have to resuscitate. We can't put that baby on mom's chest, right? Makes sense. So let's head to the radiant warmer, stimulate that baby, dry it off, and then open the airway. What we mean by that is lay that baby in that radiant warmer and lift the head up of the baby so that the nose is in the sniffing position. A jaw thrust is not appropriate for a neonate, just a sniffing position to open up the airway. If there's still no breathing, then we're going to assess the heart rate. If the heart rate is below 60, we're going to do chest thrust, or not chest thrust, but chest compressions. Okay, so we need to provide positive ventilation. It doesn't do any good for the heart to beat if we can't fill up the lungs with at least room air, right? So let's apply a mask in a bag with the nose in a sniffing position and gently inflate the lungs. Okay, watch for signs of the chest movement like you would for CPR. And then after you do that, you're going to assess the heart rate of the baby. Now, if the heart rate is over 100, that's great at that point. We're going to continue to support ventilation. All right. If baby's not breathing on their own, then we're going to ventilate them. We're using room air, okay? We're using room air because we're not concerned about necessarily about oxygenation, but about ventilation, getting air to the lungs. Okay. So once we do that, we're stimulating the baby, we're assessing the heart rate, and then 1 minute after delivery, wherever we are in resuscitation, we're going to do an APGAR. And once you work in OB and postpartum and the nursery and with newborns, you know APGAR like nothing. I mean, you just can rattle it off. Okay, so we need to make sure we document the time of delivery so that we know when that first APGAR is due. Okay, and if we don't see the baby's heart rate or hear the heart rate above 100, then we need to reposition the airway. It might be that you're not getting the ventilation to the lungs. Okay, and then recheck the heart rate again. And if it's still not up, we can use a laryngeal mask, it's called, where it's a tube that has the shape that's around the trachea that we could place in the mouth and on top of that trachea. And that way we're directing air right into the bronchial tubes. Okay, we could do that. And then, but if the baby's heart rate not at 100 and we're doing positive pressure ventilations and we know they're being effective because we can see the chest rise, but the heart rate is still not going up, then we need to do chest compressions if that heart rate is not at 60. So if it's below 60, we need to do chest compressions. Right. Once we get that heart rate up, we've got good ventilation. So if we get good airway, good ventilation, we're waiting for the heart rate to go up. Okay. Sometimes in preterm babies, we do give a little oxygen to help. But usually full-term babies, no, it's just room air. Okay. So that is kind of the neonatal key points of resuscitation. We're doing the APGAR at 1 minute, at 5 minutes, at 10 minutes, until we get to where we've got steady, good ventilation and the heart rate is elevated above 100. Okay. All right. Let's cover hyperemesis. Now, like I said earlier, if you haven't done this, you have an advantage here. Maybe. If you've already done it and you haven't done poorly, then reach out to me, okay?
Oh yeah, I will reach out.
Okay, Latoya. Okay, so hyperemesis gravidarum, remember, it's vomiting, nausea, can't keep anything down. Your potassium is low, you're dehydrated, you've probably had some weight loss. That's hyperemesis gravidarum. So this was a great scenario. Learning about the importance of prenatal care and pyelonephritis. So they brought in a second concept. Not only is this patient nauseous and vomiting, they're having trouble with a urinary tract infection. Okay. Sometimes nausea and vomiting, you're not drinking enough, you're getting dehydrated, and then you're at risk for a urinary tract infection, especially during pregnancy. So remember, during pregnancy, those tubes that come from the kidneys to the bladder, the ureters, they're kind of tortuous. And so urine tends to get hung up. We call that urinary stasis. And because of that, it increases the risk for urinary tract infections. Okay. So not only is she not drinking and eating, but she's probably not urinating hardly at all. So she's right there at the door for a urinary tract infection. So UTIs are not uncommon during pregnancy. So another key takeaway here is that This is why it's so important for patients to come to their regular prenatal visits, because every time they come in, we dip their urine and check for leukocytes, for blood, for nitrites, for leukocytes, for protein and glucose. We check all those things just to make sure things are going okay. If her leukocytes are normally high anyway in pregnancy in the urine, as well as in the blood, but there's nitrites are positive and maybe blood in the urine, those are indications of an infection. So we would want at that time to culture her urine. Okay. That's why we do one every time she comes in, we check her urine. Because remember, infections can lead to preterm labor. And UTIs are common in pregnancy, and we need to treat each and every one of them. Okay. So positive ketones indicate dehydration, and it indicates she's not been eating, right? She's predisposed to acidosis because of that. So if we deem that she has an infection, and in this case, they diagnosed her with pyelonephritis, which means she had an actual kidney infection. And pyelonephritis usually means hospitalization for IV antibiotics. This one here called Aztreonam is a very for gram-negative bacteria, especially E. coli, and it treats kidney pyelonephritis effectively, and we can't give it PO. Okay, so we need to usually, I think 24 hours they're treated for pyelo. Nowadays they're going to kick you out the door as soon as they can, right? So that's why it's really important to monitor for kidney infections or any sign of possible kidney infection. And we're talking to our patients about it. I usually will, if I have a patient that says she's had pyelo before, or that she has frequent urinary tract infections and she's pregnant, I'm a little concerned. So we'll watch her urine for a while. And if she starts having infections, we're having to treat her. I'm going to put her on a prophylactic antibiotic that she can take orally, in like macrobid, furantoin, it's called, as prophylactic to help her prevent pyelonephritis. Okay. Any questions about hyperemesis? All right. I will post that PowerPoint I just shared with you in all my classes, because I think it's valuable, and I don't think it will be a problem with the next group of OB students. So let's talk about DIC. So when are we concerned about the risk for DIC? Clotting, something is causing her body to clot up, and then she's bleeding. What are some triggers for this as far as OB? Because this is seen outside of OB too, right?
Would it be placenta abruption?
Yes, yeah, exactly. So an abrupted placenta with all that bleeding can trigger hypercoagulation to the point where it consumes all the clotting factors, trying to stop the bleeding. And then she starts rebleeding because there's no clotting factors. Okay. So DIC, that, or maybe spontaneous abortion that's incomplete. Okay, so she aborted some of the fetal tissue, but not all of it. And she's got an infection now. A severe pyelonephritis is another one. Serious.
Right?
What?
Preeclampsia.
Preeclampsia, yeah. Mm-hmm. Yep. So some other hemorrhagic orders in pregnancy, the short cervix, or incompetent or insufficient. In other words, it's not closed. The internal os is opening up, and we've got to do something to prevent early delivery. Okay, so we can do a cerclage, and we can use medications like progesterone in the vagina to support that cervix. We can also give her nifedipine to help relax the uterus, and that sometimes will help with the short cervix. Hydatidiform mole is a pregnancy or a conception without maternal DNA. So there's really no fetal tissue. It's overgrowth of trophoblastic cells. It's precancerous. So these patients will present with nausea and vomiting, pain, vaginal bleeding, large uterus, that larger than what expected. Ectopic pregnancy, pain early in the pregnancy, because if that conception, that zygote or that morula is not able to float through the fallopian tube and implant in the uterus, but it's stuck in the fallopian tube, it's going to be very early in the pregnancy. She might not even know she's pregnant yet. And if it grows in that fallopian tube's only about this wide. I mean, it's like 3 or 4 millimeter. So it's going to rupture the tube, and that we're concerned about internal hemorrhage at that point, let alone all the pain that she's having. So usually if a patient presents with pain on the right side of her pelvis, shoulder pain, nausea, we want to double check, get an ultrasound. Number one, to verify she's pregnant. Number two, to verify where that pregnancy is. Is it located in the fallopian tube, or is it indeed an intrauterine pregnancy? Because it could also be appendicitis, it could be PID, it could be all those things. So an ultrasound will kind of guide us. Diabetes in pregnancy. We're talking mainly about gestational diabetes, right? Because most type 1 and type 2s, if they can't control their glucose before they get pregnant, then they're at risk for spontaneous abortions. Okay. So most of the pregnancies we see that are diabetics are gestational type. Their hyperglycemia occurs during the pregnancy only. Okay. So we have to educate these women about exercise, watching their intake, also about checking their sugar several times throughout the day, because we might have to give them some medication if we can't control their blood glucose. So insulin needs at the very beginning of the pregnancy are low, but since these are gestational, later in pregnancy, usually after 26, 28 weeks, sometimes we do have to give them some medication to help keep their blood glucose under control. Let's see. Talked about preeclampsia. I'm going over the HESI PowerPoint, HESI topics PowerPoint. Preterm labor. So preterm labor is a labor before 37 weeks, right? So the earlier she goes into labor, the higher the risk as far as neonatal risk. Okay. So usually if she's in preterm labor and her membranes are not ruptured yet and there's no sign of infection, we want to try to stop labor. Okay, with terbutaline. Terbutaline, however, we cannot give it to someone with tachycardia or any kind of heart rhythm problems. We don't want to give it to her. And I would even question giving it to someone with any kind of heart disease. Okay. But it might be, we might be able to stop labor. And if we're able to stop it, great. We'll send her home. We'll probably send her home on some nifedipine to keep that uterine muscle relaxed and try to postpone that pregnancy as long as possible. But if she has frequent UTIs or she's had several STIs throughout the pregnancy and she goes into labor, we can almost assume the infection is causing the labor and we don't want to stop labor, right? If there's an infection in that amniotic fluid, then we need to get that baby out of that fluid, even if it's 32 weeks or younger, because that baby is not going to do well in an infection. So we don't suppress any uterine activity. We're going to promote and get her through labor so that we can treat baby in her. So during that labor, we're going to give her some antibiotics. Usually it's penicillin during labor. And we're also considering magnesium sulfate. So it's not because of preeclampsia, but it's to protect that preterm brain. During labor, we want to give some magnesium sulfate to increase perfusion of that very fragile brain. And if she is a gestational diabetic, we probably would give her betamethasone because usually glucose isn't that high. But remember, steroids will increase blood glucose. So we have to keep that in mind and make sure we're checking her glucose throughout labor. Diana's going on a trip. Diana, where are you going?
I'm
Looks
walking
lovely.
to Chipotle real quick to pick up my food.
Okay. All right. So if the membranes, premature rupture of the membranes or pre-labor, in other words, she's not in labor and her water breaks, if it gushes, whether we have to verify that it's actually amniotic fluid. Do you remember how to do that? How do you tell if it's actually amniotic fluid or urine? What's the difference in amniotic fluid and urine as far as the pH value? I'll give you a big hint. Do you remember? Which is more acidic, urine or amniotic fluid? If you're talking, I can't hear you.
Urine?
Urine, yeah. So if the pH is low, it's urine, right? So if you take your nitrazine strip or swab, if it's orange, yellow, it's urine, okay? But if it turns blue-green, it's amniotic fluid. So we can verify it that way. Okay. But if that happens and she's not in labor, she needs to go to the hospital as soon as possible, because we don't want any infection invading the amniotic fluid or the baby. We want to prevent chorioamnionitis, okay, with pre-labor rupture membranes. So if she is getting an infection in the amniotic fluid, some things we would see, because it's an infection, tachycardia, and because of the fever that she probably would have, baby, since mom and baby's vessels are right next to each other, the heat would transfer. So if mama's febrile, so is the fetus. If mom has tachycardia, so did this fetus. So we see that with chorioamnionitis. Her uterus would be very tender, and it makes sense that the amniotic fluid would be foul smelling, doesn't it? Or purulent looking, not clear white spots in it. Okay, high risk labor. So let's talk about the diabetic patient who has a macrosomic baby. What are some risks associated with a macrosomic baby?
Hypoglycemia.
Okay, the baby has a risk for the blood sugar of that newborn dropping very quickly. So you might see hypoglycemia very early. What other risks are there with
C-section
macrosomic?
because the issues with birth.
Okay,
Birthing the baby.
C-section, yeah, C-sections. These babies are big, and sometimes we don't even try any vaginal delivery. Other things would be, the turtle sign, shoulder dystocia, if we did have her in labor and she has a large baby. So the shoulder dystocia, where we have to reposition her to try to get that shoulder to pass underneath the pubic arch, which would be your anterior shoulder impingement. So the Roberts maneuver, right? And then the posterior shoulder would be Gaskin maneuver. So we have to flip her over on her back or on her hands and knees to see if we can't release that posterior shoulder. Okay, so what are some of the injuries you see with this? What are some of the newborn injuries that you see with the posterior shoulder or anterior shoulder?
Is one of them is like with their face, like the something with their face be drooping. It's like a nerve or something.
So if we have to use a forceps, is that what you're talking about? Forceps injuries for delivering a baby?
That's
If
probably what I'm
if
talking
the
about.
baby is, if the baby's not rotated correctly to make it through the birth canal, then
Yeah.
we use forceps. And yes, that can cause facial palsy. When
That's
the forceps, the facial nerve comes right down here. And if we apply forceps, we can compress it. It's not permanent. It's kind of scary for parents. So facial palsy is one thing. What else? Difficulty with deliveries, big babies, malpresentations. What else? Birth injuries. Facial palsy. What else would you see in a newborn birth injury?
Isn't there something where like the arm won't move all the way?
And the arm won't move all the way. What's causing that, Rosa?
I don't remember.
Is that
I just remember
brachial
the arm
plexus
doesn't
injury?
move right when you're checking the baby.
Is that brachial plexus?
Okay, so
That.
brachial plexus. So the nerve is damaged, Rosa, and that means it won't move at all. Okay, so shoulder dystocia can cause brachial plexus, or just a large baby, if we're trying to rotate, can cause damage to one side or the other of the neck, which is where the brachial plexus is. And yeah, when you assess your baby and you notice the Moro reflex, one side doesn't move. You know, the arms are supposed to go out like this. And if only one side goes up, then there's some paralysis over here, and you should suspect brachial plexus injury.
Did we say respiratory issues, like respiratory distress?
Respiratory issues. Okay. That's our diabetic patient usually, or our premature baby. What other injuries can occur besides brachial plexus injury, forceps, facial palsy? What other things can happen to a newborn? Kind of hard for you to spit it back out, isn't it? You could probably answer it if I showed you a question and some options, but to be able to recreate it, it's harder.
About intracranial hemorrhage?
Intracranial hemorrhage, yeah. Brain damage. Yeah, especially precipitous labor or a preterm baby that went through a traumatic labor. Okay. What about a broken clavicle? So if we elicited moral reflex on a baby with a broken clavicle, what would you see? How would that be different than a brachial plexus injury?
Well, the brachial plexus is paralyzed with the clavicle. It'll be limited movement, or
okay, yeah. So the clavicle would allow some movement of that arm. It is a reflex. Okay, it is a reflex. If we go like this, make a loud noise, or jerk the table a little bit, the baby will have that reflex. And so if it's paralyzed, that reflex is not going to work. But if it's just a broken clavicle, it's still going to have a reflex motion, but it's going to be limited. Okay. All right. So when we have a newborn, we talked a little bit about resuscitation, but remember our focus, no matter what, is warmth, skin to skin, and respiratory airway issues, making sure the respirations are adequate. So as long as those two things are going well, we're going to put that baby right on mom. So we're going to dry the baby off, stimulate, making sure the baby is passing air, and we're giving the baby warmth. And then 1 minute later, we're going to do an Apgar. Okay. So respiratory distress, what are some things you think you would see if you would suspect respiratory distress? What are some things you see in a newborn?
cyanosis.
Okay, they're blue. Cyanosis. It's central cyanosis, right? Okay, good. What else?
Wouldn't there be meconium and the what is it? Like early meconium or whatever it's called? Like that's a sign of respiratory distress? Like in the actual uterus? Like when they're giving birth? Would that be a sign? I don't know if I'm saying it correctly.
It's the other way around. If they have meconium released during their pregnancy or during labor and delivery, they're at risk for respiratory distress at delivery. Yes. Yes. Okay. What else would you see in a newborn that you think, oh no, baby's having trouble?
Nasal flaring.
Nasal flaring. Yeah, they're trying to suck in more air through their nares.
Grunting.
Yes.
Grunting, cyanosis. What else?
Seesaw respirations.
Yeah, seesaw. Their chest and their abdomen aren't working together. They might be breathing faster or trying to breathe faster.
No, retractions.
Retractions, all kinds. Up here, between the ribs, the sternal retractions. Good. Wheezing. Okay. Hypotonia. Poor muscle tone, because they're using their energy to breathe. Their arms and their legs are very relaxed and poor tone. Okay, they don't have much blood supply, or the blood isn't oxygenated for movement anyway. Okay, that's all good. So remember, cold stress. Cold stress. If you are assessing your newborn and you feel their hands or their feet and they're cool, check their abdomen. If their abdomen is cool, they're cold. So put them with mom. Skin to skin. If mom isn't available or whatever, put them under the radiant heater. Because what happens if they get cold? What'd you say, Whitney?
Hypothermia.
Hypothermia. Yeah, hypothermia is bad news for a newborn. They don't have energy. They don't have any energy to produce heat. They're dependent on us. Okay, so keep your babies warm and know the ways they lose heat. And most of you, I'm sure all of you, in your teaching plan made sure mom knew about heat loss. Okay, so keeping that baby in a ambient environment, not a lot of drafts. If it's cooler than 72 in the room, cover the baby up or put extra clothes on them. Okay, when you're bathing the baby, dry them off right away. Don't expose wet skin. Okay. Bilirubin. Bilirubin comes from broken down red blood cells. The liver breaks down red blood cells and helps to conjugate that bilirubin. So you and I have no trouble conjugating our bilirubin because we have mature livers. Okay? If you have a patient and they're jaundice, they have liver disease, usually liver disease. And a newborn that's jaundice, they have too much bilirubin too. And it's usually lack of feeding or not enough adequate feeding, or they're premature and they're behind on breaking down or conjugating. The best thing we can do for these babies is feed them. And then if we have to, an ultraviolet light. Okay, ultraviolet lights. We don't want bilirubin levels to get high or it causes brain damage. We're mostly worried about the brain with high bilirubin. Kernicterus. If we have a newborn that's delivered yellow or it becomes jaundice within 24 hours, that means there was a problem during the pregnancy. Okay, so it's usually a blood incompatibility that was occurring during the pregnancy because mom didn't get a ROGAM in the previous pregnancy. ABL or RH incompatibility with high bilirubin levels. Review your skin with the newborn. Look at the pictures. Apgar. Apnea is normal as long as it's less than 20 seconds. Newborns have apneic episodes. They stop breathing and then they'll breathe fast. And then, especially those first few days, and then they'll breathe fast and then they'll kind of stop for a second. Just kind of, if they're sleeping, they might be dreaming or something. Okay, so it's not uncommon. Let's see what else. Heel stick, collecting specimens of our newborns. Remember, we do it on the outside. So we make a V on the bottom of the foot, and it's outside of the V. That's the safest area because in the middle is where the blood vessels are, and you don't want them to bleed too much. So we do a screening for like 40 different genetic problems. What are some signs of a newborn getting sick? What would you see?
Not really eating.
Yeah, that's usually the first one, Whitney. They lose interest in eating. Lethargic, okay, hypotonic. And it mimics other things. It mimics hypoglycemia. So we have to rule it out as we go. Is our baby warm? Is the baby eating? Check the blood glucose, that sort of thing. So remember, for breastfeeding, we do supplement with vitamin D every day in a dropper. It's usually liquid, like liquid vitamins. We used to give liquid vitamins all the time. I don't know if they still do. If we recommend it when they go home, probably. But we definitely need to do vitamin D because we're not, breast milk might not have enough vitamin D in it. Okay. Swanson's Carey theory. Knowing, being with, doing for, enabling, maintaining. It just helps when it's the idea that when a parent experiences loss of a baby, the nurse being there and being available to listen and make some suggestions about, how to handle her feelings, helping her with coping, some of the mementos that they can do, is what Swanson's theory is about. And the reason we bring that up is because it usually is on the HESI. I don't think it's in your book. And then your medications. You need to know them. They're listed here. And then here's some links to cook games if you like them. Okay. So, ooh, got some chats. Hang on. All right. Anything else I can help you with? Let's see what else we need to cover. I covered part of this first PowerPoint with my 2:00 class, but we can start there. Down syndrome. Down syndrome, remember what clinical manifestations what you might see. Because Down syndrome, not all cells have extra chromosomes. So some people have very minimal signs of Down syndrome. They're not affected much. Some very severe, because maybe more cells have those extra chromosomes. But when a baby is born with Downs, you usually see the simian creases, that main crease in the hand, the palm, brush field. There are white spots on the iris is another sign. The arms and the legs are usually shorter, and their eyes are more narrow and more slanted. So those are, and maybe absent nasal bone. Those are some obvious signs of Down. What are some labs that could indicate a mom is carrying a baby with Downs?
That alpha fetoprotein.
Okay, so alpha fetoprotein, if it's low early in pregnancy, is an indication that she could be carrying a baby with Down syndrome or some kind of trisomy. Okay, you don't have to know the other trisomies. Okay, what would you expect to see if the AFP was high in mom?
Spina bifida.
Spina bifida, or some kind of neural tube defect. Okay. I don't think I shared with you earlier in the term that I had a patient, she was 19 years old, married, and she was pregnant, and we were doing her, or I should say, an ultrasound check, did her 20th week ultrasound, which we do on everybody. It's just an anatomical ultrasound. And it was her first one. And her baby did not have a full brain, only had part of a brain. And it was probably from a neural defect of some sort, might have had to do with folic acid. We don't always know if that's exactly what it is, but that's another thing we can find with low folic acid levels, not enough intake. We see neural defects like that.
So let me ask you this question. How would they swing that now with all the laws in place if you didn't want to continue with that pregnancy?
I know. They would have to go to a different state. Basically,
Oh.
they couldn't have it done in that state. They have to travel to another one. That's right. That's wrong. Wrong. Yeah. And at some states allow it at 20 weeks. But that patient, Whitney, that I had, she didn't want to terminate the pregnancy. She wanted to keep it as long as she could. And she delivered the baby, and it survived for just a few minutes. But she wanted that experience. She was pretty mature for her age.
Jesus.
But within the next year, she got pregnant again and everything was normal. But can you imagine the stress until we did an ultrasound that she might have been experiencing? Yeah. Okay. Anybody want to talk about GP status? You feel comfortable with gravidity and parity? Remember, twins, it's still considered one pregnancy. And the parities or the deliveries of pregnancy of a pregnancy are parities, and they're one. And so if you have twins, it's still one parity, but your L, as far as living births or living children, is where you would add that second baby in. So presumptive signs of pregnancy are subjective signs. What the patient is feeling that makes her think she's pregnant. Okay. It's nothing you can see. It's nothing you can measure. It's not an objective sign. It's subjective. But once we begin our exam, we find those objective signs of pregnancy that lead us to think, yeah, she probably is pregnant. Because if I see changes in the cervix, if I have a result of a positive HCG test, then I'm thinking, oh, yeah, she probably is pregnant. But I can't tell her for sure until we actually see the baby or hear the baby. Cardiovascular Molecular, look at that. Remember, a lot more blood in pregnancy. Dilutional anemia because of the expansion of plasma during pregnancy. And yet she coagulates easily during pregnancy. And I think this is just a buffer for when she goes into labor. She can lose 500 or 1,000 ml and still not be compromised in her own hemodynamic stability. But we do have to teach moms about that because we don't want them sitting for hours on end because they can develop a deep vein clot or thrombosis. Let's see. Remember, rubella is one of those vaccines that we cannot give in pregnancy. So if we do labs early, we usually do a titer for rubella and varicella just to see what mom's status is. And if they're low, then she's at risk for those diseases or those viruses. Okay, so after she delivers her baby, we want to make sure she gets a booster. And she can have it in the hospital. I think she can still get it in the hospital. Or she can get a prescription to have it done at the pharmacy or at the doctor's office. Fetal well-being. So we're talking about later in pregnancy if mom is high risk or she experienced trauma. How do we know baby is doing okay? Well, movement, right? Movement. So we teach our high-risk moms about fetal kick counts. And we have them every day to take some time out of the day to check and make sure their baby's moving often enough or long enough. Okay, so 10 kicks in an hour or 2 hours. Another evaluation we can do for our high-risk babies, and we do often, especially for babies with intrauterine growth restriction, we do targeted ultrasounds called BPPs. They're specifically looking for at least 4 things. One is they want to know the amount of amniotic fluid, the fetal heart rate. Is baby swallowing? Is baby moving? Those sorts of things. And then we want to see while baby's moving, does their heart rate go up? So we can kind of see that on the ultrasound, but we usually do a non-stress test for that. And so this is one way of evaluating how well the fetus is doing. So kick counts, BPPs, non-stress tests on our mom with a small baby is important. If they stop growing, if their growth percentile drops to 10%, they're not thriving. Okay. If the non-stress shows that the baby doesn't move a lot, or is not practicing breathing, or the amniotic fluid is low, oligohydramnios, if it's low, then we might consider delivering that baby right away because they're not thriving and we don't want to lose the baby. We don't want a stillborn. So that's another reason we do the fetal surveillance and teaching for these important patients that have these risks. Substance abuse. And, substance abuse, now smoking and nicotine is, yes, it's a substance and it shrinks a baby or it doesn't allow the baby to grow. It's not healthy, but it's not really considered abuse. Substance abuse, substance use, I think the proper terminology is substance use disorder or opioid use disorder. And and infections. STDs, it's really STIs. Sexually transmitted infections is the update. Okay. So illicit drugs. Well, some drugs aren't necessarily illicit, but they're harmful. So what are some of those illicit or harmful drugs?
Cocaine,
Fentanyl, heroin, cocaine.
Benzos.
Methamphetamines.
What'd you say, James? You said one.
he said benzos.
Benzos, benzodiazepines. Some of the SSRIs or SNRIs, anything that's prescribed, they're not illicit, but they cause a dependency. Okay. Oh, well, I'll just leave that there because SNRIs, SSRIs, they're prescribed, right? But baby becomes used to them. So when you deliver the baby and within 24 hours, they can have some kind of bad withdrawal. It doesn't last and it probably isn't harmful as much, but benzodiazepines are very harmful. If mom has been taking high doses, the baby can actually have a seizure withdrawing from benzos. Cannabis is not necessarily anything we see right away in a newborn. It's usually later in life we start noticing some things. Sometimes heart defects, but mostly autism or some kind of behavior problem with moms that have cannabis use. Prenatal abuse. I'm going to get rid of that too. Alcohol definitely is a no-no. Total abstinence during pregnancy because we don't know how much it would be. It might only be 2 ounces of alcohol. We don't know. NAS withdrawal, cocaine exposure. HIV. So how do we manage HIV? If we have a mother who has HIV and she's pregnant, how is it managed? Do you remember?
You gonna get a C-section or?
How do we know whether to do a C-section or allow her to deliver vaginally? What
Wouldn't it be based on her viral load?
Yes. So if she has a very high viral load, we're going to do a C-section so we can control the mixture of the blood. Okay. But if her viral load is low, we want her to deliver vaginally because it's better for the baby. Okay. She can't breastfeed because HIV is found in milk. We would really discourage that. I did have a patient with HIV and she breastfed her baby in spite of what we said. She had hepatitis C too, but she wanted to make sure that baby got breast milk. You know, kind of late to be concerned about your baby. Of course, I didn't say that. No way. I talked to her about her treatment, if she was still making sure she was still getting her treatment. She said yes. And she said her viral load was really low. So anyway, she felt like she was doing something right. All right, everybody. That'll be the end of that. So good luck on your HESI. I will see you in week 12 for regular class. It'll be short. Okay. Just kind of touching base, checking on you in week 12. Okay. But no class next week. Everybody knows that because you're taking your HESI. That'll be your class. All right. Thank you. Thank you all. I'll see you in week 12. If you need anything between now and then, let me know.
Thank you.
Yes, ma'am.
You're
Thank you.
welcome.
Thank you.
Thank you.
Have a good one.